Ladies and gentlemen, welcome to MedSynapse podcast series where insightful conversations in healthcare come to life. In today's episode, we're honored to have Dr. Manisha Singh, a distinguished expert in the field of pain and palliative medicine. Currently serving as a consultant at Sultan Qaboos Comprehensive Cancer Care and Research Center in Muscat, Oman, Dr. Manisha brings a wealth of experience as an onco-anesthetist and palliative medicine physician. With advanced fellowship training in palliative medicine and an executive MBA in healthcare management from the Indian Institute of Bangalore, Dr. Manisha is not only a clinician, but also a visionary leader. As the co-founder of the nonprofit organization Atmaja, she actively contributes to home care for end-of-life patients, providing vital support to their families. Today, our focus revolves around a critical topic guided by Dr. Manisha's expertise, cancer management through palliative care. Join us as we delve into the nuances of how palliative care enhances cancer care strategies and influences the overall well-being of patients during their treatment journey. This promises to be a conversation filled with insights and compassion. Welcome, Dr. Manisha.
Thank you, dear. Thank you very much for having me on this platform and letting me spread the knowledge about palliative care to the general population. Thank you very much.
Thank you so much for joining this important topic, and we're very excited to dive deeper into it. But Dr. Manisha, before we dive into our discussion, we're curious to learn more about your personal journey. What inspired you to choose palliative care as your focus?
Yeah, actually, it's a long story. I'll cut it very short. Actually, I was training in onco-anesthesia and palliative medicine from one of the very prestigious institute in India, the All India Institute, in the year 2004 to 2007. At that time I was very young and conducting palliative OPDs and seeing patients dying. I used to get into too much of depression. And so after 3 years of my residency in palliative medicine, I didn't continue it as my profession because I was also trained as an anesthetist. So for 20 years, I continued as a neuroanesthesiologist. So now finally, after a few years, when my mother ended into all these things, she had chronic end-stage diabetes with some renal issues, and I was just, not letting her go. I was behind her, getting all the investigations and treatment that done whatever was possible, which ultimately landed her into getting into recurrent this congestive heart failure. And every 6 months she used to go into pulmonary edema, then they used to intubate her, and then after 1 day she used to be okay, and then we used to extubate her. And during this time I didn't realize that how much she was suffering while I was doing all these things for her, getting her intubated every 6 months. So I ended up realizing when she finally died, begging to my auntie that please remove this tube and call me there, as I was not present in that city. And finally she had this cardiac arrest and she died very badly in the ICU with the tube inside, and which actually I shouldn't have done that. So after that I realized that there comes a point where we have to decide that curative treatment no longer exists, and the way the patient can live with a good quality of life is just letting him be with whatever things he has. And this really prolongs the survival of the patient and also with a good quality of life. And I think if I have not done all this, she would have survived. Until date, every night I think that I done this thing very wrong. And so now, again, I entered into the palliative medicine. I used all my training, what I had as a resident. And then now I just try to focus on giving comfort to all these patients who I know are not going to survive with whatever curative treatment we have. And so just letting them live the life very comfortably, whatever days they are left with. So this is how I ended up in this, and now I'm very happy and I'm very passionate about doing my work. And actually my passion lies in end-of-life care, where patients really have very less time. And so I just want to make this life and this journey to end very memorable. That's what my aim is right now. So then they don't suffer. Nobody needs to suffer during their end days, This is what I strongly believe. So that's how it started.
Thank you so much, Dr. Manisha, for sharing that deeply personal and emotional
Yeah, it's
insight
very
into your
personal.
journey.
It pains. It pains very much when you see your loved one suffering because you just didn't want to let them go. That is very painful.
I'm very sorry for your loss, Dr. Manisha. And it's
Part
very
and
clear.
parcel of life, and now I understand because it made me the human being what I am today. Being very
It's
compassionate and empathic to other human being is what actually now needed in today's world. Something happens which changes you completely in your life, and this is also one of them. The pain what you perceive, it changes you. So it's for
it's
good.
it's clear
Yeah.
that your passion for palliative care is not just a profession, but it's a calling driven by empathy and a commitment to making a meaningful impact on the lives of the patients. We
Yes.
appreciate your dedication to this crucial aspect of healthcare, Dr. Manisha. And now, to begin with our discussion today, our first question is, Dr. Manisha, how does palliative care enhance overall cancer care strategies for patients?
Now when a patient is diagnosed with cancer, the word cancer is so dangerous to hear. They lose all hope instantly when they hear the word cancer. And so, their quality of life, it starts suffering because of this. Now, what is quality of life? Quality of life is like how an individual perceives his life. For me, like when I sit in my car and I drive for 25 kilometers reaching to my hospital, I'm so happy because I want to do what I'm able to do. This is giving me the highest quality of life. But once if I headache and I'm not able to go to the hospital, you see, I disturb everybody. My family is disturbed, my patients are disturbed, even my dog can perceive that I'm not okay. So the quality of life is gone. So when you tell a patient that you have a diagnosis of cancer, he will suffer at all levels. Of course, he'll be having symptoms, too much of pain. Almost 80-90% of patients, they perceive very bad pain when they have this disease. Pain, then there is financial aspect also to it, because now he is not able to do his work. His activities of daily livings are affected. He is not able to move around. Maybe he's very weak, he's fatigued, and so he's not able to go to his work. So this affects his financial life also. And then he has these worries. So psychosocial impact also comes, that worries of how he will support his family, what his family will do. The fear of death and the depression, it all comes together. So whenever this is happening, and when you introduce palliative care at this stage of life, when the diagnosis is just being made, first of all, the symptoms are controlled with this. We treat all the symptoms what patient is going through. And once you are cured, like if I'm cured of my headache, I am able to stand up and work all. So when once your symptoms are controlled, at least something of your life is controlled. So first we control your symptoms. Second, talking to the patient, making a rapport with them, and just making them understand now what is disease, and from here how his journey will be, what all treatment options he has. This relieves some kinds of anxiety from there. And the studies have shown, there are systematic reviews showing that after 12 weeks of this introduction of palliative care, and after 24 weeks, we see that there is quite a amount of decrease in anxiety, and the coping skills of the patients are increased. Also, when you and the palliative care is not only about the patient, it's also about the caregivers. So when you empower the caregivers, you tell them also what's going to happen, how they have to support the patient, and in turn we support these caregivers also by all the education and empowering them of doing small things for their patients. So this is a holistic approach where we involve everything from physical symptom management to psychosocial, spiritual, and even the existential crisis. It also comes to this patient, because then they start questioning, like, why me? So this is a multidisciplinary team approach with palliative care. It's not that only the physician goes and see the patients. We have all the team support. Like we have occupational therapists, we have physiotherapists, we have chaplains, we have social workers who talk about the social aspects of their life. So as a team approach, we try to handle everything they are going through from the starting of the diagnosis only. So this journey becomes very less painful for them. And also when they start on the treatment like chemotherapy and radiotherapy, These all are toxic therapies. They have all the side effects on these patients. So like chemotherapy. So chemotherapy induces nausea, vomiting, peripheral neuropathy, diarrhea, skin changes. There are so many things. With radiotherapy also, same things happen. The pain increases. So like we treat them for this also. And sometimes like we give presumptive treatment also, thinking that he's going for radiotherapy, he's bound to have mucositis in head and neck cancer. So I start his treatment preemptively only before starting the therapy, so that these side effects are delayed and they are not that painful. So the compliance to the treatment also increases. Otherwise, people will leave the treatment between. I've seen the patients leaving the treatment because of the side effects. So treating these complications, treating the other symptoms which are coming because of the disease and because of the treatment, both, this makes a patient go through this journey very effectively. And then and the time comes when we have discussion also. Communication is one of the most important part of the palliative care, and how you communicate with the patient and the family. Sometimes we have to tell them that this is not working. Sometimes first line not working, go to second line not working, go to third line, and after third line, it's rarely anything is left for them. So in this process, they somewhere come to know that now end is nearing. So this takes up for a serious discussion with the family and with the patient, and also the advanced care planning. If patient is very educated and if the culture permits, the advanced care planning can be done with the patient, because we tell them now, this is going to happen, what are your wishes, what you want to do. And there are so many things in a person's life. He is not only the person, he is all ecosystem for his family. He had some dreams. Some patient have dream of making a home, some have some for holidays, and very small things of wishes they have in their life, and whole their family is connected to this person. So it's suddenly, we can't say to them like, okay, now this is the end, we don't have any treatment, and okay, now we are not going to do anything. This we cannot do. Here comes the part of the palliative physician again, when we tell them that there are so many things we can do to make your life comfortable. We are not abandoning you. So this all process, the palliative care is a big spectrum, starting from the early diagnosis, going through to the curative treatment, when we support them, where we call it as a supportive therapy or a supportive medicine. And when finally the patient is declared that he is no more curable, then the proper palliative care starts with the end of life care. So end of life care, people think that when you give them to palliative care, it is end of life. It is not end of life. End of life is proper end of life care, which forms a very small spectrum of the whole big palliative care medicine, or whatever you call the big broad specialty it is. And it doesn't end here. After the death of the patient, the bereavement is also part of the palliative medicine. So it is a whole big thing. End of life care is a small thing when it comes actually when patient is actively dying. But we take care of the patient from the start of the diagnosis to the bereavement. This is how it helps. Like oncologists, they keep on doing their things. They do curative treatments. We take part in this process by helping them doing this, by treating the symptoms, by treating the side effects, talking to the patient, making him comfortable, making the family comfortable, so that they go through this journey very comfortably, whatever may be the outcome. This is what broadly, it's a holistic approach involving everything. Like as a Dame Cicely Saunders described, not only the pain, but total pain. The total pain, which involves psychosocial, social, psychosocial, then it comes the physical symptoms. There are so many aspects, the spiritual concerns, everything. It forms a pain, and we target it from everywhere. So this is in what the palliative medicine does to the patient when they are going through this journey.
Thank you so much, Dr. Manisha. It's truly impressive how palliative care contributes to comprehensive cancer care. Now, moving on to our next question. What challenges do healthcare professionals face in promoting early adoption of palliative care in cancer treatment, and how can they address them?
Yes, there are so many barriers for this early integration. The first of all, and the most important, is oncologist willingness to give us the referral. There are so many policies and so many, at the global level, the WHO has adapted this palliative care as one of their part in the national health policies, and told all the countries to include palliative care in their national health policies. And so, starting from the global level, coming to the to the local level, there are many barriers. First, as I told you, when I see it is thankful in my hospital, it is not because we have a very good big department of palliative care and our oncologist, and we have totally integrated with each other for this care. But there are different types of integration we need right now, like oncologists. Now, if they know we can do these things, they will refer to us. And sometimes the training of oncologists is like that, for everybody. We think like that, this patient should be cured. Why he's not being cured? Okay, I've tried first line of therapy. I may go to second. I may go to third. There are so many options left, but ultimately, nothing works, or very few patient it works when it goes to third line. And so the time comes when they should realize that nothing is working, and the early they give the patient to palliative care, the better will be their prognosis and the survival. Because sometimes the studies have shown that the survival may increase by 4 to 6 months if given early to the palliative patient. But if you go on trying all the therapies to them, and when they refer to us, maybe 24 hours to 48 hours before when the patient dies, it becomes very frustrating for us also, because we are not able to help this patient in any ways, and he dies suffering with all the invasive things going on with him, taking all the chemotherapies and tolerating all the side effects. So the education and the training, and it's not about oncologists. Palliative care is not only for cancer; it is for everything, even for non-cancer patients, even for geriatric patients when they don't have any chronic disease. But frailty is one of the things from where they can be referred to palliative care. So now, as there is a big service gap in this thing, because now patients are not dying, people are not dying because of the communicable disease, but they are living longer, and then they'll die because of the non-communicable disease. So all non-communicable disease, you take stroke, dementia, Parkinsonism, this end-stage diabetes, end-stage heart disease, COPD, everything can be covered by palliative care, because it's about the disease. It's not about the disease, it's about the person and how we treat that person. So actually it should come into the undergraduate curriculum, and everybody should be exposed to the palliative care and the principles of palliative care, so that whatever field they are working, they should know that this case should be now given to palliative medicine, and they should be involved early, so that patient is comfortable during all this journey. So education at the level of undergraduate or even the postgraduate curriculum, training should be given to the doctors, to the oncologists, and there are 3 levels of specialists in 3 levels of palliative care physician. One who can provide very basic, like anybody can do it. There are training modules for the basic palliative care where it can be done. Then comes the specialist, where in the local health center or somewhere where people are trained little bit more, so that they can take care of this patient at the community level. Not everybody needs to come to the tertiary center if they have any issues at the end of the life. And third is like a tertiary academic research center, where a full department acute palliative services are given, like which is one where I am working. Like here, if patient with terminal rectal cancer comes with malignant obstruction, intestinal obstruction. Now here nobody else can touch them, and I know how to conservatively treat that, because they are not candidate for surgeries. So here they need acute palliative services, and we treat all these emergencies here. So there are different levels, and for different levels different trainings are required. So all the integration of these people is very essential. Knowledge and awareness of the public also is very essential, because palliative care is they can demand from their oncologist. It is the right to a comfortable death is also a right as per the right to palliative care also. So they can demand to oncologists. If people know, if community know that this also the option is available, where they can really live longer, little bit longer, and with comfort care, they can tell their oncologist to transfer them to palliative care. So this is also one thing. The another thing, it comes to the drugs. The morphine or the opioids are the mainstay of our treatment plan, because cancer pain is such a deadly pain. Nothing works when the disease is metastasized. So we need opioids, and availability of opioids, as you know, is very, very difficult with all the opioid crisis going around in the world, especially in US, when it was misused for chronic pain. But the thing is, if we consider this as opioid crisis, our patients are also suffering from opioid crisis. of the total population in the world, only 14% of people can take the palliative care services, and of them, very less number of patients are able to get the morphine as a painkiller, which is such a cheap drug. My country, India, being the one of the big exporter of the morphine, but only 2% of our population, of palliative population, is able to get morphine because of the government regulations. Because it is a narcotic drug, there are so many regulations and misuse, and so many things are there. And because of this, our patients are suffering. And I call this as opioid crisis, because they are the patient who should get it, because this is what we're going to make their death peaceful. So drug availability is really very, very difficult for many patients, especially in low economic zone countries. This is one of the big challenges what we are facing. Rest of the things we can still, the things are going on. Governments are rising to the need of the palliative care. There are so many organizations now all over the world which are helping to grow the community awareness. And so slowly, I think there is a growing optimism for palliative care, and people are taking it as a option for the patients suffering from life-limiting illnesses.
Now, moving on to our next question, Dr. Manisha, could you please highlight the collaborative efforts between palliative care specialists and other medical professionals in cancer care?
Yes, it's a multidisciplinary approach what we take, and we always need the help of other physicians whenever the palliative care is required, because it's not that if patient is undergoing depression, I'll send him to psychiatrist. If he's having some urine infection, I'll send him to another separate specialist. It's not. We make as a multidisciplinary team, which is a supportive team. And in this team, we have everybody. And we as a team then see the patient and discuss the patient and decide on the treatment of this patient. So that the patient doesn't have to run around anywhere. Another very newly important thing which we are doing is we are getting the support of interventional radiologists also in this case, because when patient comes with recurrent ascites, tapping him every time and inserting the needle every time doesn't work, because malignant ascites, it reforms. So interventional radiologists, they help us in putting maybe USG guided catheter. Sometimes the need arises for some gastrostomy when patient comes in obstruction and you can't operate. So gastrostomy, jejunostomy, this all can be done by interventional radiologist or endoscopist. So there are the physicians, and even now palliative surgery also we are including in this. When sometimes patient comes with spinal compression, the tumor compression is there on spinal cord, the surgery is done by, it's only with the palliative intent the surgeries are done. So all the physicians, they are on board with us. They understand how much it is important for these things to patients to undergo, because it's never that we'll not do anything for this patient. For if the symptoms are there, and if the particular intervention can help improve this symptom and ultimately his quality of life, we go through that. Okay, so this is how we take help of all other specialties whenever we feel that this is only for symptom relief and not for the curation.
Thank you so much, Dr. Manisha. And coming to our final question for the day, are there any recent advancements in palliative care that have positively impacted cancer patient experiences?
Yes, of course, there are. Artificial intelligence is everywhere. So how can we be apart from this AI things? There are so many papers right now of artificial intelligence being used for the prognostication. Prognostication is one of the most important part, because when I go to a patient and counsel them, a family or the patient, may ask him how much time I have. Okay, this is very difficult answer to be given, because nobody knows. So we give them estimate of maybe your patient will be for few days, weeks or months, never in numbers we give. So this prognostication can be done when we have some typical scores when we see the patient, their activities, then some blood investigation, CRP and albumin levels. There are the scores for this, and according to that scores, I decide how much days the patient have. So this can be made easy, and maybe I hope it is it is bulletproof things that it will not change, because we as a doctors tend to overestimate the prognosis, right? If patient, I'll tell 5 days, maybe patient will go in 3 days, because I overestimate. And there are the studies who say that physicians overestimate. So there is nobody can definitely know. So they are taking help of this AI to prognosticate depending upon all his biochemical parameters and his functional status, his performance status, and everything. So AI is coming there. Then telemedicine is after COVID. Telemedicine has really helped in this specialty, especially when patient lives in remote area and where there is no services, and patient is having any typical, sometimes a severe breakthrough pain these patients have. So for that pain also, if we can just guide them from here only, there's no need to run around for them. Bringing a patient who is bedbound is so difficult from anywhere to the hospital. So we can stop this emergency visits of the patient by telemedicine. So telemedicine, another is app based for caregivers, and also the VR. The VR is coming now too much. When patients, one patient of mine said that she wants to visit some Greece or somewhere. Okay, so I told my VR guy to make a module of that, and he showed to her that, and she was so happy, because in VR you see that you are there actually. So this is one part of VR, but there are many other uses of VR also in palliative medicine. But for me, this is the most important, that they are able to fulfill their wishes, what they wanted to do in their life before saying bye. So VR in this field is also very helpful. So these are the few things which are coming new, apart from the drugs, and there are so many things, drug delivery systems. So that's all.
Dr. Manisha, as we conclude our conversation, we want to express our deepest appreciation for your generosity in sharing your knowledge on cancer management through palliative care. Thank you so much. And I'm sure your insights have not only enlightened us, but have left a lasting impact on our understanding on importance of palliative care.
For giving me this chance. Thank you.
Thank you so much once again, and we're looking forward to many more podcasts together.
Okay, sure. Anytime.
Thank you, Doctor.
Thank you very much.
Thank you so much. And to our audience, we extend our heartfelt thanks for tuning in. We hope Dr. Manisha's expertise has been as enlightening to you as it has been for us. Remember, the journey of medical knowledge is a continuous one, and we invite you to stay connected with MedSynapse podcast for more captivating discussions with experts like Dr. Manisha. Thank you so much. See you soon. Goodbye.